Precocious puberty in girls is a relatively common condition which often presents to the clinician at a very late stage when not significant intervention is possible. It is very important to diagnose the girls with precocious puberty at an appropriate age and do required treatment and evaluation so as to avoid long term complications, particularly in the form of compromised growth in these individuals. We'll focus on the key questions that are to be answered in a girl with precocious puberty as to when do we call it precocious, what are the causes, and how to evaluate. The definition of precocious puberty is largely a statistical definition, and we consider a puberty to be precocious if a girl is having pubertal development more than 2 standard deviations score earlier compared to that particular ethnicity. In general, precocious puberty is considered at the age of onset of any breast development or pubic hair development before the age of 8 years or periods happening before 9.5 years. Another aspect which is important to understand is that there is a concept of discordant puberty, that the usual difference between the onset of breast development and menarche is around 2 years. So if that difference is less than 1 year, that is a discordant pattern of puberty, is again an indicator of significant pathology in the form of a peripheral precocious puberty. So before we really go ahead in terms of what really precocious puberty is, just a touch base regarding basic aspects of pubertal assessment. And we all know that breast staging starts from stage 1 to stage 5, and in this regards we have the papilla elevation, the formation of mound, secondary mound, and the adult form. The two most important phases to look at in terms of breast evaluation are stage 2, which is any breast evaluation. At this point of time, there will be a sudden growth spurt and girl will grow by around 8 to 10 centimeters per year over the next 2 years when they had menarche, following which the growth is around 5 to 8 centimeters. So roughly from breast stage 2 to final height is around 20 to 25 centimeters in a physiological condition. In somebody who is having a rapidly progressive puberty, this figure may be lower compared to that. So if you have a girl who has precocious puberty and presents to you at breast stage 2 or 3 with a height of 120 centimeters, you have to be really cautious in this regard. The gap of 2 years between thelarche and menarche is the usual phenomena, but in conditions wherein there is sudden estrogen production, like a large ovarian cyst in the setting of McCune-Albright syndrome, hypothyroidism, or an ovarian cyst, there might be a situation in which there is hardly any breast development and vaginal bleeding starts to happen. And this is a situation one needs to be very cautious and think of a possibility of a more peripheral precocious puberty. One confusion which often happens in this regards, particularly with obesity, is whether it is actually true precocious puberty or just a lipomastia. To distinguish the two, we need to actually approximate the thumb and finger and feel for any resistance. If there is a resistance, it is indicative of a breast nodule and true thelarche, while if there is no resistance, it is suggestive of lipomastia. We also need to be aware about the endocrine changes which happen around puberty, and what is most important is that the FSH levels tend to rise at early stages of puberty and they tend to overlap different stages of puberty, while LH levels are a much more reliable marker of pubertal onset, and therefore we need to look at LH in a focus sample. There is a extreme variability and pulsatile secretion of both LH and FSH, and therefore these samples should actually be pooled 15 minutes apart, and the 3 samples should then be pooled for assessment. Estrogen is very unreliable amongst most assays which are available commercially, particularly at lower level, and therefore one doesn't need to be rely upon estrogen, and it's the vaginal mucosa which is a better marker as far as estrogenization is concerned, and we'll discuss that a bit later. LH is clearly the best marker as far as pubertal onset is concerned. Levels which are less than 0.1 are indicative of prepubertal state, while those who are more than 0.6 are indicative of pubertal state. 0.1 to 0.6 indicate a borderline situation in which a GnRH agonist test, in which a GnRH agonist is given subcutaneously and levels are checked at 0, 2 and 4 hours, is helpful in making and establishing the further diagnosis. So once we know that this girl actually has precocious puberty, the next question is what really is causing the precocious puberty. And for that, we need to have a basic idea about the hypothalamic pituitary gonadal axis. And as we can see, it is the LH and FSH which is produced by the pituitary, which is responsible for production of estrogen through the action of granulosa and theca cell and produce estradiol. Kisspeptin is now emerging as the most important pointer and regulator as far as pubertal onset and growth is concerned. And in this regards, if you look at the etiology of precocious puberty, it can broadly be classified into central or peripheral precocious puberty. In girls, the most common peripheral source of estrogen production is ovarian cysts, which happens in the setting of hypothyroidism, McCune-Albright syndrome, or a functional ovarian cyst, but accounts for less than 5% of all causes of precocious puberty, and it's central precocious puberty which is most important. This is in contradistinction to boys where peripheral precocious puberty is more common, particularly in the setting of adrenal hyperplasia, adrenal tumor, or testicular tumor. So when you talk about girls, it's mainly central precocious puberty and it's mostly idiopathic precocious puberty. It may also occur in the setting of a CNS tumor, CNS insult. If we talk about boys, as we said, tumor, testicular tumor and gonadotropin independent precocious puberty along with CAH are responsible for a significant proportion of peripheral precocious puberty. While in girls, peripheral precocious puberty is rare and happens predominantly in the setting of hypothyroidism, ovarian cyst, or McCune-Albright syndrome. So how do we distinguish between a central and peripheral precocious puberty? And the clinical presentation is extremely important. As we had alluded earlier, the peripheral precocious puberty in girls typically is associated with hyperestrogenic state. So their estrogen levels suddenly increase. Therefore, it's a very rapidly progressive disorder. It is a condition in which there could be hardly some breast development and vaginal bleeding would happen. So it's a discordant pubertal development. And of course, LH and FSH levels would be low or undetectable in the setting of peripheral precocious puberty in girls. So now we have decided about what is the cause and whether the girl has precocious puberty. The next step is how to evaluate and proceed further. And for that, we can really classify precocious puberty in girls into whether it is incomplete variants in the form of just breast development, vaginal bleeding or pubic hair growth, or complete development of precocious puberty, which can then be either dependent on gonadotrophins in the form of a central cause or it is gonadotrophin independence. Coming on to the incomplete form, girl presenting just with breast development may represent either a condition which is known as isolated thelarchy, predominantly found in girls around 1 to 2 years of age who have normal bone age, who do not have any other signs of precocious puberty, have a FSH predominant response with low LH levels and multiple small cysts in the ovaries, which is known as microcystic ovaries. This may also be the initial phase of a progressive precocious puberty, and therefore we need to have evaluation in this regards. Menarche is not a true term if we talk about isolated menarche, and I would put it isolated vaginal bleeding would be a correct term, because in the absence of breast development, it is not going to be dependent upon any endocrine cause because estrogen would not be there in the system. It is a non-endocrine gynecological diagnosis which requires evaluation for local causes like foreign body, abuse, tumor, and infections. Isolated pubarchy is a common condition which basically means that the pubic hair growth has happened and no other growth has occurred by now before the age of 8 years. Usually pubic hair growth occurs along with thelarchy but may actually proceed by around 6 to 12 months. This is because the adrenal axis is entirely independent as far as central, the GnRH dependent axis is concerned. If there is just pubic hair development and it is associated with accelerated bone age, some other features of virilization like clitoromegaly or hypertension, one needs to be really cautious about the possibility of an adrenal hyperplasia in the form of either 21 hydroxylase deficiency or 11 hydroxylase deficiency, or in the setting of an adrenal tumor, especially if it is a rapidly progressive virilizing disorder. Isolated pubarchy is now being increasingly observed in the setting of small for gestational age babies who have rapid catch-up, and it is considered to be the first marker of quote unquote metabolic syndrome and is a known risk factor for developing metabolic syndrome, polycystic ovarian disease, fatty liver disease, dyslipidemia later in life. So if there is a child who is small for gestational age, who has a rapid catch up and has pubic hair development around 6 to 7 years of age, we need to be really cautious about the possibility of developing these metabolic complications later in life, therefore needing to be very strict as far as dietary and nutritional factors and physical activity is concerned in that setting. Gonadotropin independent precocious puberty in girls is quite rare and mostly occurs in the setting of an ovarian cyst and very rarely a estrogenic adrenal tumor, which should be worthy of a case report. Hypothyroidism is a unique condition which is associated with precocious puberty, and unlike all other causes of precocious puberty, these girls are short and have delayed bone age. Every girl with precocious puberty should be tall. If you have a short girl with precocious puberty, 99% it is hypothyroidism and 1% it could be a hypothalamic lesion causing precocious puberty and concomitant growth hormone deficiency. In untreated primary hypothyroidism, large elevations of TSH acts on the FSH receptor, causing ovarian cysts to form, producing a hyperestrogenic state, precocious puberty with discordant pattern, early menarche, and the bone age is still late. McEwen-Albright syndrome is a rare cause of precocious puberty but has multi-system implications. It should be considered in young girls who have rapidly progressive puberty, who have fluctuating pattern of puberty in the form of some breast development, occasional vaginal bleeding, advanced bone age, and particularly should lead to evaluation for possibility of fibrous dysplasia or bony lesions or cafe au lait spots. McEwen-Albright syndrome is a somatic mutation in the GNAS gene, the gene which is responsible for production of cyclic AMP, and in this setting, these particular cells of the body where the mutation is continue to produce a large amount of hormones, causing multi-system endocrine involvement dependent on the distribution of mutation. The most classic findings include precocious puberty, polycystic fibrous dysplasia, and cafe au lait spots, but other associations like hyperthyroidism, growth hormone axis, Cushing syndrome, and hypophosphatemia should also be considered in this regards. Gonadotropin dependent precocious puberty is the most common cause of precocious puberty in girls and is usually idiopathic in over around 95% of cases. Young girls with rapid onset, particularly around 2 years of age, who actually may have menarche by this time, with a history of what is known as gelastic epilepsy or uncontrolled laughter-like spells, should be considered for the possibility of hypothalamic hematoma, and rarely trauma, radiation, hydrocephalus can present with similar picture. So in this background, the three questions that a clinician who is facing a girl with precocious puberty has to answer is that, is it really precocity? If it is precocious puberty, whether it is complete or incomplete, and finally, what is the cause of precocious puberty? So for confirmation, we have to look at the vaginal mucosa, which is the best marker of estrogen status of a girl. Estrogen assays, as we discussed, are extremely poor markers because of the huge variability at the lower end of those assays. So to assess vaginal mucosa, we have to spread the leg and separate the labia and look at the introitus. If the vaginal mucosa is pale, it would mean that there is estrogen exposure, but if it is red and glistening, it is a non-estrogenized state. Bone age has to be advanced in precocious puberty with the exception of hypothyroidism. Now a concept of slowly progressive precocious puberty is coming up, in that some girls have earlier development, but it is slower and the time taken to menarche ultimately is more, resulting in a static menarche age. So if the bone age is not advanced, we don't need to be very concerned in this regards. If the endometrial thickness is more than 5 mm, one needs to be really cautious about the possibility of complications which may happen in this regards, and particularly menarche may be imminent. So now we'll go forward to this case. 7-year-old girl with thelarche, breast stage 2, no periods, pubic hair stage 1, LH, FSH and estradiol all undetectable. Bone age is 7 years. So do you think this is precocious puberty? In the absence of growth acceleration, bone age advancement and normal parameters, it's very unlikely to be precocious puberty. So one needs to be really cautious whether this is actually stage 2 breast or it is simple lipomastia in the setting of obesity, and which was the case that we observed. 6-year-old girl with thelarche, and we see definitely the breast is around stage 3. The girl is tall for her age and her bone age is extremely advanced. So at 6 years, she is around 7 years as far as the height age is concerned, but her bone age is 11 years. So this girl, although is looking tall, is still 4 years compromised as far as growth is concerned, and this is a definite issue of concern, and unless we do something, this girl is going to land really short. She is the most ideal candidate for a GnRH analog which needs to be given. The next issue, once we have confirmed precocious puberty, is that whether it is a complete or an incomplete precocious puberty. And in this regards, if it is just breast development, we have to look at the bone age, look at the ultrasound for endometrial thickness and LH FSH levels. If we have a FSH predominant response with microcystic appearance appearing in the ultrasound, and we have normal bone age, it's most likely a isolated thelarche. While advanced bone age, increased LH and some endometrial stripe is more suggestive of a true precocious puberty presenting with thelarche. In isolated pubarche, one needs to look into the possibility of congenital adrenal hyperplasia and really adrenal tumor. As I said, isolated vaginal bleeding is a non-endocrine gynecological diagnosis, needs evaluation by a gynecologist for trauma, tumor and infections. So we have this 2-year-old girl with thelarche, breast stage 3, no bleeding, pubic hair stage 1. Investigations show LH is low, FSH is high, E2 is on the lower side. Ultrasound shows multiple small cysts, and this is a classical case of isolated thelarche. 7-year-old girl with vaginal bleeding, no breast development and no pubic hair development, and this is a red herring. Any girl who doesn't have a breast development and has bleeding, it is non-endocrine. Vaginal mucosa confirm the same, it is red and glistening. LH levels is low, FSH may be high in this age group. So this is a non-endocrine cause. Gynecological evaluation revealed a foreign body. So now we know whether it's a complete precocious puberty. The next issue is whether it is dependent or independent, and in this regards we need to look at clinical and biochemical parameters which indicate peripheral precocious puberty. So if it's a rapidly progressive disease which has a discordant pattern in which menarche is happening within 1 year of thelarche and the LH levels are low both basal and GnRH stimulated state, it is indicative of peripheral precocious puberty. So this is a 7-year-old girl who presented with thelarche and vaginal bleeding within 6 months of breast development. Her height is here and weight is here, and this is the most unusual growth chart you will see in a girl who actually has precocious puberty. She is short for age, and you should have a clear focus now in looking at a significant pathology. And the bone age is also retarded. So height age is 4 years and bone age is approximately 5 years. This is a classical presentation of hypothyroidism in which the TSH levels will be very high, and since TSH and FSH have analogy, it acts on the FSH receptor to form large ovarian cysts, and they have large breast development. This is the classic example of what is known as von Wieck-Grumbach syndrome, a highly treatable condition which just by thyroid supplementation, every condition should be improved, including ovarian cyst, precocious puberty, and growth failure. So any short girl who has early puberty, think thyroid would be a key message. This is a relatively common condition, particularly if the thyroid disorder is not picked up at the right age. Ovarian cysts can be huge, and often they have been advised surgery, and just by thyroid replacement, things would improve in terms of progress. 4-year-old girl with early puberty had thelarchy 3 months ago and had vaginal bleeding, which indicates a discordant pattern of puberty. LH-FSH is undetectable and estrogen is high, which indicates peripheral precocious puberty. Ultrasound showed ovarian cysts. Diagnosis of ovarian cyst was made, but it was not a functional ovarian cyst because a few months later she had fracture and fibrous dysplasia. So if you have a condition wherein you have a girl who has discordant puberty at an early age, look for cafe au lait spots because they cannot be missed in McCune-Albright syndrome. So just to summarize the evaluation of precocious puberty in girls, look at the extent. If it's just pubarchy, look at adrenal causes. If it's vaginal bleeding, look at local causes. If it's complete, what is the bone age? If bone age is retarded, it's the classic case of hypothyroidism. Normal bone age would indicate a slowly progressive form in which we don't need to be very aggressive in terms of evaluation and management. If it is advanced, look at LH-FSH levels. If they are prepubertal, think of peripheral precocious puberty, look at ovarian cyst. If it is central, think of a neuroimaging. And what need to be understood is that the chance of finding a CNS pathology is extremely rare between the age of 6 to 8 years. And during this period, a routine MRI is not indicated. However, if you have a girl who has an onset before 6 years of age, neuroimaging becomes extremely important. Coming on to the management, it will depend upon the type of precocious puberty. In central precocious puberty, if there is advancement of bone age, compromised adult height, GnRH analogs are quite effective in terms of response. For congenital adrenal hyperplasia, steroids can be given. Ovarian cysts typically do not require any specific surgery unless there are complex ovarian cysts or there is a chance of torsion. McCune-Albright syndrome is a complicated situation, difficult to treat. Selective estrogen receptor modifiers or ER antagonists, which are estrogen receptor antagonists, have recently been tried with some success in this condition. But these conditions require long-term follow-up and should be managed by pediatric endocrinologists. Long-acting GnRH analog therapy are highly efficacious in management of precocious puberty with good improvement as far as height and other parameters are concerned.